We now move on to Chapter 13 on opioids in the course Drugs, Behavior, and Society. The learning objectives for the chapter are to list several historical uses for opium, including early recreational uses of opium and its derivatives, to describe the supply, distribution, and trafficking of opium and heroin in Canada, to explain how the profile of the typical opioid abuser has changed in Canada, to describe the pharmacokinetic properties and mechanisms of action of the opioids, to describe the current medical uses for opioids, to discuss some of the concerns associated with the use of opioids, and to describe the key findings from Insight, Vancouver's supervised injection facility. So naturally occurring substances derived from the opium poppy have a long history of medical use, perhaps 6,000 years long. Opioids relieve pain and reduce diarrhea and subsequent dehydration. And opium delivers pleasure and relief from anxiety, so opioids also have a long history of recreational use. So, Papaver somniferum, or the opium poppy, is an annual flowering plant that grows 3 to 4 feet high, most likely originated from the Middle East. Opium is produced and available for collection for only a few days of the plant's life, where opium harvesters use a sharp, clawed tool to make shallow cuts into the unripe seed pods. The resinous substance that oozes from the cuts is scraped and collected. And this raw opium is the substance from which morphine is extracted and then heroin is derived. We look at the early histories of opium. The most likely origin of opium is the hot, dry, Middle Eastern country many millennia ago. Egyptian papyrus circa 1500 BC describes specific medical uses to prevent excess crying of children. In Greece, it had an important role in Greek medicines. In the Arabic world, opium is used as a social drug. Its use spread to India and China through trade. And in 1000 AD, Arab physician wrote a description of opioid addiction. The Arab physician Avicenna wrote about the use of opium preparations. In Europe, its use widely began in the 16th century. Thomas Sydenham, considered the father of English clinical medicine, developed an opium preparation called laudanum, a combination of strained opium and other ingredients. We look also at the history for writers in opium. The writer Thomas de Quincey described the pleasures and pain of regular opium use. Other authors who wrote about opium include Elizabeth Barrett Browning and Samuel Taylor Coleridge. When we look at the opium wars of 1839, opium smoking spread following the introduction of tobacco, where opium was eaten while smoking. In 1729, opium smoking in China was outlawed, but smuggling became widespread, and mainly from India, where poppy plantations were abundant. The British East India Company was involved in the opium trade, legally in India and illicitly, but indirectly in China. The pressure grew, and eventually a battle broke out between the British and Chinese in 1839. The British won and were given the island of Hong Kong and broad trading rights. The dilemma of the opium trade for the British was profitable, but at times immoral. When we look at morphine, we're really looking at, in 1806, the active ingredient in opium was isolated. And so the active ingredient, morphine, was 10 times as potent as opium by itself. It was named morphium after Morpheus, the god of dreams. In 1832, another alkaloid of opium was discovered, named codeine, from the Greek word for poppy head. So morphine was clinically useful, a pure chemical of known potency. And so when we look at, the medically useful characteristics, it was clinically useful. It was a pure chemical, and it, like I said, had a known potency. And so the major increase in the use of morphine occurred because of two developments, one technical and one political. So the development of the hypodermic syringe in 1853 could deliver morphine directly into the blood instead of orally. At that time, it was thought that morphine by injection would not produce the same degree of craving for the drug as seen with the oral use. And lastly, it became widespread use during wars that provided relief from pain and dysentery. Many veterans were dependent on morphine after this, and dependence was later called the soldier's disease or army disease because of when it was picked up. When we look at heroin, we're looking at two acetyl groups attached to morphine creates diacetylmorphine. It's given the brand name heroin when placed on the market in 1898 by Bayer Laboratories. The chemical transformation made heroin 3 times as potent as morphine, and through its increased lipid solubility, it made it much quicker to enter the brain. And so marketed as a non-habit-forming substitute for codeine, but it was later linked to tolerance and dependence. So here we have raw opium. It's the substance from which morphine is extracted, and then heroin is derived. You can see it next to pennies. You can see the size. That doesn't actually take much in order of raw opium to create morphine. So when we look at opium and heroin supply, distribution, and trafficking in Canada, because poppies do not naturally grow in Canada, they need to be imported and distributed through illegal and criminal channels in South and Southwest Asia, which are the primary suppliers to the Canadian market. For decades, illicit heroin use has been considered one of the most central elements of high-risk street drug use in North America. And because poppies don't grow naturally, the primary source of opium in Canada is South and Southwest Asia. Opium power is popular among young adults in Toronto and Vancouver, where it is cheap and it has an unconventional high. And a major source of illicit opioid in Canada is prescription opioid medication. Most knowable would be Oxycontin. So we look here of the distribution trafficking in Canada. Here are all of the naturally occurring, the semi-synthetic, and the synthetic types that are derivatives of heroin. So, and directly from opium. So we have morphine and codeine. They're agonists. We found in Tylenol 2. We look at semi-synthetics, heroin, oxycodone ASA, like Percodan. They are all agonists as well. We look at synthetics, though. We look at methadone, which right now is devastating, addicts across Canada right now. Methadone, all of those, tramadol, they are all agonists, and they are synthetic forms of heroin, opioids. And then when we look at things like Suboxone, and naloxone, those are all agonists or agonist-antagonists. But they are completely synthetic form, laboratory created. So for decades, again, illicit heroin use has been considered one of the central elements of high-risk street drug use in North America. Recent data suggests substantial growth in the prevalence of illicit opioid use in North America. The upsurge has predominantly involved prescription opioids, or analgesics like morphine and hydromorphone and oxycodone rather than heroin. And so the Opioids study in 2001, we look at the non-medical use of opioids in Canada. The Opioids study was comprised of illicit opioid users in Edmonton, Montreal, Quebec City, Toronto, Vancouver, Fredericton, and St. John's from 2001-2005. And study participants were regular illicit opioid users not in treatment at the time of baseline assessment. And the study reported that heroin use had decreased significantly across study sites between 2001 and 2005. But prescription opioids, rather than heroin, were the most prevalent misused drugs. One suggested explanation for the change in the use from heroin to prescription opioids is the substantial rise in medical use of the prescription opioid. In 2005, Canada ranked first in the world in per capita consumption of hydromorphone, second for morphine and oxycodone, and third for hydrocodone. And so prescription opioids within the context of medical treatment of pain have been identified as a major contributor to the development of opioid dependence and abuse in Canada. Heroin use has been restricted to small fractions of Canadian society, with only 1% of Canadians reporting past life use. And so the use of, Vancouver and Montreal had a higher number of heroin-only users. And, really when we're looking at prescription opioids are more readily accessible than heroin is. And stereotypical face of the addicts has changed to include prescription drug users for non-medicinal or self-prescribing purposes. So, again, there has been a significant shift in illicit opioid use for the prototypic, heroin addict to one using prescription opioids in Canada. And again, that is due to the substantial rise in medical use of prescription opioids. And really, we're looking at the market rise in non-medical use of these drugs in Canada. And again, Canada ranked first in the world per capita in some of these medications. And so the indications that both medical and non-medical uses precipitate opioid dependence and overdose. And so the percentage of illegal opioid users entering methadone maintenance treatments in Toronto currently using prescription opioids either with or without concurrent heroin use. And when we look at things such as fentanyl, fentanyl is approximately 100 times stronger than morphine. And the fentanyl transdermal patch is a slow-release patch initially intended mainly to treat patients suffering cancer-related pain who have built up a tolerance to other opioids, but now being abused quite highly and very, very, very easy to overdose on. And so prescriptions of opioids for treatment of pain is identified as a huge contributing factor to opioid dependence and abuse. Go to your doctor, you have pain, they prescribe a synthetic opioid for the treatment of pain, and then someone becomes dependent on it and then addicted. So between 2001 and 2005, annual consumption of analgesic opioids increased substantially in Canada. Oxycodone use increased by 230%, fentanyl by 159%, and morphine by 28%. Huge, huge increase. Heroin use has for many years been restricted to a small fraction of any population studied. So only about 1% of adults reported ever having used heroin in their lifetime, and 0.2% reported using in the past year. So numbers have remained relatively stable for at least a decade now. And so although heroin dependence is often associated with intravenous use, dependence can occur via any route and that produces the behavioral or physiological responses. And so this would be the typical thought of a heroin user injecting using an IV method. But we are seeing such an increase of pills specifically causing addiction. So the most popular prescription opioids are various brands of hydrocodone and oxycodone, such as Oxycontin, Percocet, Vicodin, or our Lortab. Most taken orally, but when used recently, they are sometimes snorted and injected. And so prescription opioid use far exceeds cocaine use, but is markedly lower than marijuana use. There has been concern about their relatively high rates of non-medical use of opioids and their potential for toxic consequences when misused. And it has led Health Canada, the US, and the FDA and drug manufacturers to take preventative measures. So when we look at the pharmacology of opioids, raw opium is about 10% morphine by weight, and a smaller amount of codeine. And so with the added acetyl groups, heroin passes through the blood-brain barrier faster, making it more potent than morphine. And so researchers searching, albeit unsuccessfully, for ways to separate the analgesic and dependence-producing effects of opioids have developed a variety of prescription painkillers. So really, what we're talking about is an opioid antagonist. It's a drug that blocks the action of opioids. That can stop the actual effects of, the opioid derivatives. And we're talking about naloxone, Narcan, and nalorphine. And really what the effects are, it reverses the depressed respiration from opioid overdose. It precipitates withdrawal symptoms, and it prevents dependent individuals from experiencing a high from subsequent opioid use. And so the alarming increased rate of opioid-related deaths, many involving fentanyl contamination, have led to a reduction in restrictions of naloxone availability and the provisions of naloxone kits to opioid users. You can go to any pharmacy. They will train you on how to use naloxone on or Narcan someone. And you can Narcan someone several times, and it will not injure them. One of the things you learn through that course is that you have to be careful, because when, let's say, an addict is Narcaned, you are reducing their high instantly, and they can wake up being aggressive, upset, disoriented, and so there is some caution around using Narcan, and you need to be trained in order to use it. But at any pharmacy, you can pick up a kit and have that in your home, in your car, and ready to be used. So when we look at the mechanism of action of opioids act on selective receptors in the brain. And there is endogenous opioid-like products of the nervous system and endocrine glands activate brain opioid receptors. And so there are enkephalins, which are morphine-like neurotransmitters found in the brain and adrenals, and endorphins, morphine-like neurotransmitters found in the brain and pituitary gland. And some researchers have associated them with the so-called runner's high. So natural and synthetic opioid drugs, as well as endogenous opioids, act on multiple types of opioid receptors in the brain. And so here we have, what the morphine, codeine, and heroin, really what they look like. Based on carbon, oxygen, and nitrogen. And they all have a similar structure in the center, and then change from that. And they bind to those receptors and activate certain things. And so when we look at both endogenous opioids, natural and synthetic opioid drugs, they act on multiple types of opioid receptors, the mu, kappa, and delta receptors in the brain. Okay, so there's the mu receptors, and mu receptors are activated by morphine. Mu receptors are found in the brainstem and the medial thalamus, and they are responsible for supraspinal analgesia, respiratory depression, euphoria, sedation, and decreased gastrointestinal motility and physical dependence. And, mu receptors have subtypes, including the mu1 and mu2. And mu1 receptors are related to analgesia, euphoria, and serenity, and the mu2 are related to respiratory depression, prolactin release, dependence, anorexia, and sedation. We look at the kappa receptors. They are activated by ketosilicine, and kappa receptors are found in the limbic and other diencephalic areas, the brainstem, and the spinal cord. And they're responsible for spinal analgesia, sedation, and respiratory depression. When we look at the delta receptors, they are activated by delta alanine, delta leucine, enkephalin. And the delta receptors are in the brain, and their effects are actually not well studied. They may be responsible for the psychotomimetic and the dysphonic effects of opioids. But when we're looking at opioids, there are beneficial uses for them. When we look at pain relief, the major therapeutic indication for opioids is the reduction of pain. Patients report awareness of pain, but less aversion and/or suffering. And opioids reduce the emotional response to pain and diminish the patient's awareness of and response to the aversive stimulus. And typically they cause drowsiness, but do not induce sleep. We look at the beneficial uses is also the treatment of intestinal disorders. They reduce colic and counteract diarrhea and the resulting dehydration. They act by decreasing the number of peristaltic contractions. And an opium solution known as paregoric is still available for relief of diarrhea. And when we look at cough suppressants, codeine has long been used to reduce cough and remains available in prescription cough medicines. And they do this through actions in the cough control center of the medulla. That's what it suppresses. And non-prescription cough medicine contains the opioid analog dextromorphin, and it produces hallucinogenic effects in high doses, but also has that same reaction to the medulla in cough suppression. And so really, we look at the causes for concern. Really, we're talking about the dependence potential. We're looking at tolerance. And tolerance develops to most effects from both medical and recreational usage, which means increased dosage is needed to maintain the same effects as it would have originally when first taken. And there is cross-tolerance that exists among all the opioids. And there is a psychological process that plays a key role in tolerance. Dependent individuals develop a conditioned reflex response to the stimuli associated with taking the drug. And so when we look at the admissions to Cambridge Medical Withdrawal Management Services for opioid detoxification or detox between 2000 and 2004, we are still seeing overall an increase in most of the areas. And most significantly, we are looking at oxycodone increasing, but heroin staying pretty stable over the years. But an increase in control release oxycodone and other prescription opioids. And so when we're looking at physical dependence, the symptoms of withdrawal appear in sequence following the timing of the most recent dose and the individual's history of the use. So opioid withdrawal is unpleasant, but it is rarely life-threatening. So now we have things like methadone, which is a long-lasting synthetic opioid that produces withdrawal symptoms that appear later and are less severe than those from heroin. And then when we look at clonidine, it's a drug used to treat high blood pressure. It diminishes the severity of withdrawal symptoms, indicating that opioid receptors and alpha-androgenic receptors are found together in some cells. So, the sequence of appearance of some of the abstinence syndrome symptoms. So withdrawal we're talking about. The signs, there is a craving for the drug and anxiety. Okay. There's yawning, perspiration, runny nose, teary eyes. That happens about 14 hours after the last dose of heroin and morphine, and 34 to 46 of methadone. As you can see, it actually prolongs the withdrawal symptoms. Increase in above signs of pupil dilation, goosebumps, tremors, hot and cold flashes, aching bones and muscles. It starts 16 hours after the last dose of heroin and morphine, and again 48 to 72. And so when we look at the increased intensity of the above, plus insomnia, raised blood pressure, increased temperature, pulse rate, respiratory rate, and depth, and the restlessness and nausea starts between 24 to 36 hours. And then, the increased intensity of those symptoms, plus curled up position, you can get vomiting, diarrhea, weight loss, spontaneous ejaculation or orgasm, an increase in the red blood cells in the blood and an increased blood glucose that starts between 36 to 48 hours are withdrawal symptoms that are common in withdrawing from opioids. And so we're looking also of physical dependence. So the symptoms of withdrawal appear in the sequence following the timing of the most recent dose and the individual history of use. And again, it is not, it is unpleasant, rarely life-threatening. Okay. And so we look at psychological dependence. Opioid use provides positive reinforcement, right? Positive effects reliably follow the use of the drug. I take an opioid, I feel good. And that reinforces my wish to continue using. And fast-acting injectable opioids are most likely to lead to dependence because of how fast it happens. There's a direct relation of how soon it happens to the psychological dependence or psychological effects that it does have. And so when we look at negative reinforcement, the use of the drug removes withdrawal symptoms, right? So I start to feel withdrawal. I don't wish to feel that withdrawal. I use the opioid and it removes my withdrawal symptoms. And so opioids for which withdrawal symptoms occur rapidly are most likely to lead to a more robust dependence. So other causes of concern are acute toxicity. So opioids depress the respiratory centers in the brain. And this causes breathing to be slower and shallower. And the effects with alcohol are additive. So more alcohol with it makes it a stronger high. Opioid overdose diagnosed by the opioid triad. There is coma, depressed respiration, and pinpointed pupils. And the behavioral effects include the clouding of consciousness. Occasionally there can be nausea and vomiting, and again, this can be counteracted with one dose or several doses of naloxone that again block those receptors, stop the high, and stop the depressed respiration most importantly, so the individual continues to breathe. So when we look at chronic toxicity, there is no scientific evidence that exposure to opioid drugs cause long-term damage to any tissue organ system. Chronic toxicities are typically associated with methods of use. So long-term injection use is associated with infections, abscesses, and the spread of blood-borne diseases such as HIV, tetanus, and hepatitis. When we look at the life of a person that would be addicted to heroin, they would need 3 to 4 injections daily to prevent withdrawal. And the expense is $30 to $100 per day. So it would be a very expensive habit, the cost of drugs and the paraphernalia. There's a high risk of overdose due to variability and potency of different illicit batches, right? We can't always know on the street what you're getting, what the potency is, and if it's mixed with other things. And so a lot of the times overdose happens accidentally because of the potency in the opioid. There are health problems associated with an injection habit. We're looking at skin infections, blood-borne infections, malnutrition because money is spent on heroin and not food, and masking of early symptoms of illness. So you miss the symptoms of what's really going on because you are busy in your habit and using. And some users mature out with time. As they get older, less, life takes over, less likely, but, that doesn't mean that a lot of that happens. So misperceptions and preconceptions. Not all users experience euphoria from the initial dose. Tolerance to negative effects may develop more rapidly than tolerance to positive effects. And withdrawal is often similar to a mild case of the intestinal flu. People usually don't become dependent after one dose. And probably about 1 million opioid-dependent people in the U.S. and 2 to 3 times as many heroin chippers or occasional users are happening. Across Canada, heroin is the predominant drug of abuse in intravenous drug users. And so when we look at research addressing the need of injection drug users in Canada, drug use must be addressed as a public health issue, not a illegal activity, but a public health issue. And so the Canadian Drug Strategy Initiative balances a population-based approach with the goal of decreasing consumption and related risks and severity of adverse consequences arising from drug and alcohol use, and while not necessarily reducing consumption. And so harm reduction strategies include supervised injection sites to ensure that safety, ensure the proper injection, the clean needles, etc., to stop other public health issues such as HIV and AIDS, hepatitis, etc. So harm reduction strategies include supervision injection sites and Insite in Vancouver's downtown east side. So when we look at Insite, Vancouver has this place called Insite. It's a supervised injection facility. It's an experiment in the population health. Insite provides nursing services and care for skin abscesses to users, and the program is a controversial one, and the annual operating cost was $3 million in 2006. So Insite was granted an exception from drug enforcement laws allowing injection of illegal drugs on the premises and provides clean needles and safe area for injection. Again, on-site nurses provide use, education, and care. And really, when we're looking at it, for every dollar spent, 4 are saved. The clients are 33% more likely to get into a detox facility just from education and providing, access to counseling or other resources. And so when we look at safe injection sites, such as Naomi, about 75,000 and 125,000 people inject drugs in Canada, with cocaine and heroin being the favorite injectable substances. And the street availability of prescription analgesic opioids like hydromorphone and morphine have been on the rise in recent years, as is the prevalence of intravenous use of heroin in large cities such as Vancouver and Montreal. In 2006, a randomized controlled trial with injectable heroin was conducted to evaluate the effectiveness of heroin-assisted treatment in the Canadian context, and targeting those who did not respond to conventional treatment options. And so when we're looking at the study to assess long-term opioid maintenance effectiveness, or SALOM, diacetylmorphine maintenance therapy should be delivered in settings where prompt medical intervention is available because of the risk of overdose and seizures. The study to assess long-term opioid maintenance effectiveness clinical trial followed to test the hypothesis of hydromorphone dilaudid is as good as diacetylmorphine for intravenous heroin replacement. And the Naomi and Salome projects are the only heroin maintenance programs to take place in North America. So, really in an attempt to deal with injection drug users, there were supervised injection facilities, and they gained recognition in the 1980s in reaction to growing incidents of public injections, drug overdoses, and sharing needles. And there are currently 120 safe injection facilities in 10 countries. Despite the number, they are evidence of benefits to society they are still hotly debated. In Vancouver, Insite was established in 2003 and serves intravenous drug users living in and frequenting the neighborhood known as the downtown east side. Okay. Downtown East Side is one of North America's most impoverished areas and is also known as Skid Row to many of the locals. The majority of housing in the area are small, undesirable, single-person dwellings. And, an estimated 5,000 intravenous drug users lived in the downtown East Side. 20 safe injection facilities, research studies have validated the effectiveness of the Insite safe injection facility operation. The site maintains a database which facilities research and develop other life-saving strategies. Nurses and staff educate visitors on safe injection practices and provide healthcare, counseling, and treatment. So there is a relationship between safe injection facilities participating in drug use behaviors. The benefits of Insite include directly availability of clean injection equipment, and the change in behavior among drug users. In an 18-month period, 336 overdoses occurred on site. The majority of cases involved heroin, and so staff nurses responded to overdoses and no fatalities resulted. And so research data, was collected and has provided evidence to inform prevention approaches. And so, resources, accessibility and available resources. Resources include clean environment, sterile equipment, medical supervision over 12 injection booths, education, addiction treatment services, and referrals to care. So allowing the user to come and learn and have access to these education and addiction treatment services increases the potential for someone to take those resources. So located above Insight is an associated detox and withdrawal management facility called On-Site, and it's capable of supporting 12 clients at a time to detox off medically. Since opening in 2003, On-Site has over 3.6 million visits and 12,000 registered clients. 20% of Insight clients have access to detox services. It's pretty amazing. And so when we look at a cost-benefit analysis, the cost-benefit analysis performed in 2010 determined an average benefit-to-cost ratio of 5.12, indicating a positive economic return. And so benefit-to-cost ratios for other conventional drug interventions, so drug treatment programs, drug courts, voluntary drug treatment in prison, have on average not been shown to be superior to On-Site. And so why increase drug use? So really, a study of Insight influences on relapses and cessation of current users and increase in binge use showed no differences due to having such a facility. Okay, so it doesn't actually increase drug use. And really, when we look at the Canadian reaction, the Canadian population is fairly supportive of Insight and opposes moves by the Conservative government to close the program. Some misconceptions about safe injection facilities still need to be overcome. 26% of Canadians still believe that Insight provides drugs to clients as opposed to supervising their use. And so the discord between scientific evidence and current policy needs to be closed. So the key statements in summary. Opium was used in its raw form for centuries, both medically and for pleasure. Opium had significant influences on medicine, literature, and world politics through the 1800s. Various synthetic opioids are now available, along with the natural products of the opium poppy, and these drugs all act as opioid receptors in the brain. Opioid receptors are normally acted on by the naturally occurring opioid-like products of the nervous system and endocrine glands, endorphins, and enkephalins. The opioid overdose triad consists of coma, depressed respiration, and pinpoint pupils. Death occurs because breathing ceases. And combining opioids with sedatives can increase the likelihood of respiratory depression, death. And again, lastly, harm reduction strategies include safe injection sites such as Insight that have shown significant improvements and a lower death rate among heroin and opioid users just for having the facility.